a 44-year-old male with a known history of multiple bony lumps presence with a rapidly growing, painful shoulder mass. I am showing you an AP radiograph, along with axial T1, T2, and post-contrast fat-saturated T1 magnetic resonance images of the proximal humerus. Please describe the findings.
The radiograph demonstrates lobular rings and arcs calcification surrounding a humeral metadiaphysis osteochondroma, with other exostoses in the medial humerus. The magnetic resonance images confirm a large, lobulated, T2 hyperintense soft tissue mass surrounding the humerus, with cortical destruction at the osteochondroma neck and peripheral septal enhancement.
What is your primary diagnostic concern?
The findings of a growing, painful soft tissue mass, with chondroid mineralization arising from a pre-existing osteochondroma, are diagnostic of a secondary chondrosarcoma.
What is the predisposing syndrome in this patient, given the multiple bony lesions?
The presence of multiple exostoses in the humerus and ribs indicates multiple hereditary exostoses, an autosomal dominant disorder.
What are the key clinical and imaging criteria used to distinguish malignant transformation from a benign osteochondroma?
Key criteria include new onset pain, growth of the lesion after skeletal maturity, and a cartilage cap thickness of greater than 1.5 centimeters in adults on magnetic resonance imaging.
Why does the soft tissue mass exhibit very high signal intensity on T2 weighted images? And what is its characteristic enhancement pattern?
The high T2 signal is due to the high water content of the myxoid cartilaginous matrix. It characteristically shows peripheral lobular and septal enhancement on post-contrast images.
Where does secondary chondrosarcoma typically metastasize, and what staging study is required?
Metastatic disease is rare, but most commonly involves the lungs. A chest-computed tomography is the required staging study to evaluate for pulmonary metastases.
What is the differential diagnosis for an osteochondroma associated with surrounding soft tissue inflammation or calcification?
Differentials include an adventitial bursa overlying the cartilage cap, which can cause pain and show fluid signal, and tumoral calcinosis. However, a bursa lacks a nodular, enhancing soft tissue mass or cortical destruction.
Finally, what are your clinical management recommendations?
I recommend wide surgical excision with limb salvage reconstruction. Radiation therapy and chemotherapy are typically not effective for chondrosarcoma, as these tumors are highly resistant.